Hello, my name is Tiffany Thomas. My thesis analyzed a parent training called Parent-Child Interaction Therapy with Children with Autism. Autism is a lifelong pervasive condition. Individuals with this disability typically interact, behave, communicate, and learn differently on a wide continuum of severity. There is currently no known cause for autism, and data suggests it is on the rise. Researchers believe the cause to be a combination of genetic and environmental factors. Families with children with autism often report poor relationship quality. A positive correlation exists between children with autism who exhibit maladaptive behaviors and parental depression, as well as anxiety in typically developing siblings of children with autism. Parents report a high number of resources utilized for support and treatment. Parents may spend approximately $17,000 in additional costs per year. As the prevalence of autism continues to rise, so does the use of complementary and alternative medicine, or CAM. This may include dietary interventions, music and drama therapy, pet therapy, sensory integration, or vitamin and herbal remedies. 88% of parents reported use of CAM in the past. As autism continues to become more and more prevalent, choosing a treatment that is evidence-based is of utmost importance in order to achieve successful results. According to the American Psychological Association, EBP is the integration of the best available research with clinical expertise within the context of patient characteristics, culture, and preferences. One of the most effective EBP treatments for autism includes early intensive behavioral intervention, or EIBI, which is a comprehensive treatment derived from the principles of ABA. It is often implemented at approximately 3 years old for up to 40 hours per week and focuses on teaching skills in a repetitive and concise fashion. Studies have found that 50% of children with autism show significant gains in outcomes to EIBI. The greatest strength and foundation of this behavioral approach is that it is scientific with measurable outcomes. Parent-Child Interaction Therapy, or PCIT, is a parent training that was developed as an empirically supported parent training intervention for treatment of problem behavior in typically developing children aged 2 to 7 years old. Children receiving PCIT demonstrate a greater reduction in behavior problems and increase in compliance, and their parents exhibit improved parenting skills, which may lead to greater relationship satisfaction. Research on PCIT is largely limited to typical clinical and laboratory settings. The objectives of the present study target incorporating the procedures and principles of the intervention within the context of in-home services for children with autism. All participants included young children with autism receiving intensive in-home ABA therapy 6 days per week for at least 18 months. All children were recommended PCIT as a result of various maladaptive behaviors such as aggressive behavior, noncompliance, stereotypic behavior, and lack of social interest in others. PCIT intervention was conducted at least once per day for 10 minutes in length. Sessions occurred within the home of each participant in various locations throughout their home. Parent, child, and ABA therapists were present for every session. Some examples of activities utilized during the intervention included Mr. Potato Head, tag, puzzles, Play-Doh, or Simon Says. Activities presented during sessions encouraged interaction and were reinforcing to the child. A number of measures were utilized to examine behavior of parent and child. The pre-post-test PCIT measure reported frequency of appropriate and inappropriate behavior of the child. Appropriate behaviors included sitting with parent, engaging in eye contact, or sharing. Inappropriate behaviors included any aggressive behavior, crying, or whining. During the first phase of the intervention, child-directed interaction, or CDI, frequency of positive verbal responses were recorded. These behaviors included behavior description, reflection, and labeled praise. In addition, frequency of negative verbal behaviors were recorded, such as asking questions, giving commands, or general negative talk. Mastery criteria was a score of 30 positive verbal interactions and 0 negative interactions for 5 consecutive sessions. Once mastery criteria was met, the supervising BCBA determined to what degree PCIT sessions had become reinforcing to the child. It is important that the child finds PCIT sessions reinforcing before moving on to the next phase when demands are being placed, regardless of mastery. Compliance of parental commands during the second phase, which is the parent-directed interaction, or PDI, was also recorded. Only one demand was placed on a child until mastery criteria for compliance was met, which was 100% compliance for 5 consecutive sessions. Once a specific demand was mastered, a demand of increased difficulty was implemented. Once the child is proficient in complying with multiple commands in a single session, the supervising BCBA considered discharge from the intervention. At the conclusion of the study, parents completed a satisfaction survey measuring the social validity of the intervention. A non-concurrent multiple baseline design was used. During the pre- and post-PCIT phase, parents interact with their child as they typically would with no feedback given from the therapist. Parents and clinician discussed all procedures and expectations outlined in the PCIT manual prior to the start of the intervention. The CDI phase of PCIT is completely led by the child. A predetermined location within the home is chosen, along with predetermined activities that will be available during the session. Therapists observe the parent while they interact with their child and provide immediate and concise feedback on parent behavior. At the conclusion of the session, the therapist provides more in-depth feedback to the parent and discusses any questions or concerns that arise. The PDI phase begins just like the previous phase and allows the child to direct and lead what activities they will engage with. During the session, parents insert demands at various times that must be complied with. All demands are predetermined prior to the session. The child is heavily reinforced for compliance with labeled praise, attention, and occasionally a highly preferred reinforcer. If the child does not comply with the demand, a hierarchy of procedures for compliance is implemented. For example, first a warning is given, then directing the child to a timeout chair, then directing a child to a timeout room. Session ends following a timeout. Overall results of the PCIT intervention for parents indicate a consistent increase in positive interactions and a decrease in negative interactions with their child with autism across all participants. On average, participants increased their positive interactions with a parent by a frequency of about 25 and decreased negative interactions by 10.1 following the conclusion of the study. Across all parents, positive interactions continued to increase after the initial CDI phase where skills were acquired and negative interactions maintained low levels. Pre-test and post-test results indicate a consistent increase in child-directed positive interactions such as sharing and a decrease in child-directed negative interactions such as hitting or crying with a parent across all participants. During baseline phase, participants exhibited a low frequency of positive child-directed interactions with a parent and a high frequency of negative interactions with a parent. Following the intervention, post-data showed substantial results of high frequency of positive interactions while negative interactions were almost completely extinguished. On average, participants increased their positive interactions with a parent by a frequency of about 12 and decreased negative interactions by a frequency of 5 following the conclusion of the study. Results demonstrated an increase in positive parent behaviors, positive child-led interactions, and compliance, while also reducing negative parent behaviors and child maladaptive behaviors across participants. Parents rapidly decreased negative interactions and increased positive interactions shortly after the start of the intervention. At the completion of the study, parents reported the intervention was effective in modifying their child's behavior and improved parent-child relationship satisfaction. They reported they would continue to implement PCIT after the completion of the intervention and would recommend PCIT to other parents. PCIT is a parent training in which parents become aware how they are inadvertently reinforcing maladaptive behavior and punishing adaptive behavior. The dynamic between parent and child may become strained as a result of misaligned contingencies, and the presence of the parent may even become a punisher. The PCIT procedure is effective because it creates awareness and gives parents power and control. Through the various phases of PCIT, parents learn to encourage and reinforce positive behavior while not attending to maladaptive behavior. Over time, when the contingencies are properly aligned, the dynamic of parent and child greatly improves with the use of reinforcers contingent upon appropriate behavior. Essentially, parents learn to use their attention to encourage appropriate behavior, what language to use when placing demands, and how to properly enforce consequences for noncompliance. At the end of PCIT, parents should have an awareness they did not have before in regard to contingencies set forth and a skill set that will reinforce positive behaviors in the future. Limitations in the use of a non-concurrent multiple baseline design include the inability to distinguish history effects that coincide with the implementation of a given intervention. For example, one of our participants attends school where implementation of several interventions was executed in an attempt to extinguish problem behavior and increase compliance between child and teacher or aide, and interference of those interventions cannot be ruled out. Of course, with any single case design, it's often argued that the limited number of participants is a limitation in itself. Another possible limitation includes the lack of measurement in the quality of the interactions between parent and child during intervention. Although the present study measured the frequency of desired behaviors, it does not account for the substance of the interactions. Clinical implications include implementing PCIT within the confines of a home environment, which eliminates the need to generalize results in a setting where acquired skills will be applied. Based on the results, parents gain a deeper understanding for how to take control of contingencies their child responds to and encourage appropriate behavior. Future studies should analyze and measure the quality of positive social interaction demonstrated during PCIT. In addition, future studies should include a more thorough, systematic evaluation within the home environment. One parent in particular reported PCIT implementation with other family members, such as grandma or cousins. It may prove useful to implement PCIT with individuals other than parents. Overall, as parents increase their use of positive interactions and decrease their use of negative interactions, their children also increase their own use of positive interactions and decrease their use of negative interactions by the conclusion of the intervention. The current study provides further evidence for the effectiveness of PCIT in treating young children with autism within an ABA setting.